think I'm missing one panelist. She's coming on her way. So good afternoon, distinguished guests, panelists, ladies, gentlemen. It's a really beautiful day outside, so I apologize that we have no natural light here. But just as a taster for things to come, I would just like to make a little announcement for later. So we have a session now that should last around 2 hours to 6 o'clock. Then there's an hour break, and then at 7 o'clock we have a reception upstairs where there's lots of natural light to welcome our new President and CEO of MSH, Marion Wentworth. So we're very excited about that. So just wanted to offer the fact that there's some really nice hors d'oeuvres for later on, as well as sunshine. But in the meantime, I'm really excited about the panel that we have here today and to welcome our panelists. As I've said, I'm just looking over there. Please tell me when our keynote speaker comes, won't you? Yeah, okay, great, thanks. So welcome, my name's Catherine Taylor, and I'm the Vice President with responsibility for Health Programmes Group at Management Sciences for Health. For those of you who don't know Management Sciences for Health, just a 2-minute overview. We're an international non-profit organisation that works in low and middle income countries. We've been working for over 40 years, around 47 years now, in some of the most difficult and challenging settings. And particularly our focus is on building resilient health systems that really meet the needs of women, children, adolescents, men globally. Today I'm really excited to have this opportunity to moderate this panel. This panel is really timely, I think, as we think about many of the countries that we live and work in around the world are affected by crisis. Those crises can be natural disasters such as earthquakes in Haiti, or they can be person-made, and that is the crisis of conflict and war in which many of us are involved in many different countries. And I just have to say that this countries in crisis or dealing with crisis, this is not something in low resource settings. As many of you have heard today, in my own country, in fact in a city very close to where I was born and brought up, we suffered a horrific act of what we think is a terrorist act when over 22 at this point in time people were killed going to see an Ariana Grande concert, and over 60 people were injured. And I think it's important for us to realise that when we're talking about crisis, we're talking about a global issue, not something that just affects a country somewhere else. So I just wanted to bring that to our attention today. And on that, just to remind us that WHO estimate that over 1.5 billion people are living in settings that are affected by crisis or that are actually recovering from crisis. And our keynote speaker today, Dr. Bernice Dahn, who's the Minister of Health and Social Welfare from Liberia, is somebody who can really help us understand the lessons that you learn when a country goes through a crisis, as Liberia did with the Ebola crisis. So often in these settings, and a theme that's been resonating throughout the last couple of days that I've been here at WHA is the theme of women and children, and particularly the most vulnerable populations. And these are the ones that really suffer when we are in a time of crisis. For example, we estimate that around 66% of maternal mortality happens in around 25 countries, many of which who are affected by fragility caused by crisis. Very recently, of course, we've been dealing with the crisis of Ebola and also Zika virus. Not only did we have to deal with those crises as they were happening and support the people who were affected by them, but we're also looking at health systems that actually were not resilient in the time of crisis, and we saw a situation where routine services such as immunization, maternal health care, eradication efforts on the infectious diseases, including malaria, all stopped and actually went backwards while we were dealing with this crisis. So not only were the deaths as a result of the actual Ebola virus itself, but many deaths related to the effects of having a system that crumbled under a threat such as Ebola. So the panel today is a panel of distinguished guests who are dealing with these issues of supporting health system resilience in different settings, from the global setting at WHO to a donor's perspective to a frontline health worker. And I hope that we then can see at each level of the system how it is important that we all have similar goals and we're all working to the norms and standards that are set by our normative agencies such as WHO. So what I think I will do, we had hoped that Dr. Bernice would be able to give our keynote speech initially at the beginning of the panel. What I will do, as I don't think she's arrived yet, we'll go to the panel itself. So I'd like to start off the panel today by welcoming Dr. Ed Kelly. Ed is the Director for the Department of Service Delivery and Safety at WHO and is dealing with many of the strategic issues that we face in times of crisis. He has a distinguished career in many settings, working overseas for over 10 years. And he's worked also in the US Department of Health and Human Services and also for US funded projects. So he really has a breadth of knowledge around these issues. So I would like to welcome him to give his remarks. I'm going to start off with a question to Ed. So in times of crisis such as Ebola, such as in times of conflict, what's the role of WHO and UN organizations in supporting those efforts, both globally and at a country level?
Thanks very much for the question, and also thanks to the organizers for having us here. And having worked over the past years with Bernice, before she became minister, my experience with her is that she's always so solicited by literally everyone in the room, including ourselves. I think we've had her introduce 3 separate resolutions on digital health, people-centered care, and sort of health systems recovery bits. So she's very, and plus, as people know, there's this small issue of voting that is going on the thing. And if we stay here long enough, maybe we will find out while we're all sitting here together. But anyone who has the best Twitter connection is required to raise your hand if you see something. But it can't be a rumor; it has to be the actual vote. But in any case, so I'm sure, yeah, she will be here. But I think this question of WHO's role and then the UN family's role is quite different, because WHO, until very recently, had a role in sort of in the health recovery and resilience work that was very much around setting some of the standards and norms and trying to guide the policy work, and secondarily as an operational agency. Now, with the launch of the WHO Emergencies Program, led by my colleague Pete Salama, we have moved very squarely, and member states asked us to do this, into an operational role in countries. And I'll give a couple examples. But I think it's important that this session has taken this question of vulnerable women and children. So implicit in that is the idea of equity around these questions, and vulnerability occurs at a national level with this whole idea of resilience, but it's always the sort of equity issues and vulnerability issues are always greater within country than between countries. So you can have countries that are more vulnerable than others, but that the difference between those countries of vulnerable and less vulnerable countries will be much less than the question of which populations within those vulnerable countries are at most risk. And it's quite clear, you could see in the Ebola outbreak, but then also in other crises and other outbreaks, that the vulnerable only become more exposed during the breakdown in service delivery. And the rural poor, the urban poor are the ones who suffer the most. And for me, this question of response to recovery to resilience, I think has there's both sort of our own externally imposed view on it and then the internally imposed view. Most of the countries we are dealing with are perpetually vulnerable, or perpetually in this state of little mini outbreaks or protracted conflict, the ones that we're talking about. So my own experience, for instance, in Guinea, I was there, I worked a lot in Guinea speaking French, bad French according to my daughters, but they asked me today, actually, if this session was going to be in French, and I said, no, it's in English. They said, oh, thank God, Dad. But when I went there, we were told sort of the first trip there, one of the key things, this was height of the Ebola outbreak, social distance. It's actually, if you are careful, it's actually quite difficult, unless you are taking care of Ebola patients, it's actually quite difficult to get Ebola if you were going there, as I was. But we were visiting hospitals, so we were careful about the social contact, and the director of the hospital, literally in front of his staff, comes up and says, WHO is here, and gives me this big hug. And, at the time, I asked the staff about that, and they said, well, Guinea has been dealing with this. You're dealing with this now, sort of starting the last number of months. Guinea has been dealing with this for sort of 10, 12 months. There's a mentality, and in many countries we deal with, they're dealing with these conflicts and these situations for much longer. So there's a mentality that gets there. So moving from recovery, a response to recovery to resilience, it's a little bit of an externally imposed idea for these countries that are in a bit of a constant state of recovery in some ways. But that said, like for us in Ebola, to take two examples, and then I'll finish, on Liberia and Syria. So for Ebola on recovery, the resilience, the sort of recovery plan for Liberia was specifically targeted and was termed a transformation plan. So the idea was that work on a national quality strategy and building back routine essential health services was built in from the very idea of the recovery, and focusing on quality services as a bridge has been one of our entry points on this. I think it focuses on the need to look at long-term systems development alongside meeting the immediate emergency needs. And I think that's something that is difficult to do unless you bring everyone to the table, so the emergency folks and the systems folks, and building so that the recovery plan does not exist outside of the national 10-year health plan. And that was an expressed desire for Liberia and something they built in from the start. And just briefly to finish, on Syria, for instance, most of the work that we've been involved with, we had 53 interagency convoys. We've delivered 208 tons of medical and health supplies, 2 rounds of national multi-antigen vaccination. So there's a lot of front-loading of activities that has been happening there. But we've also been looking at at the same time, building up critical services that can stay there afterwards. So mental health services in Aleppo, Damascus, Hama, Homs, etc., rural Damascus even, and looking at how we strengthen the primary and secondary health centers in the 11 governorates. So these are activities that have to happen at the same time if you're going to be able to make those. And the selling point we have to donors on this is that you can have immediate impact with big money that comes and with helicopters that fly things places, but that stuff disappears and sinks into the morass of dysfunctional governance unless you start to build the systems that are behind that. So strengthening district health management teams and creating the policy link to the national plan afterwards. So I think that it's what drives financing, and it's also what drives the reform and service delivery. So those would be my messages.
Thanks very much, Ed. Can I just have a follow-up question to you on that issue? You talk about the importance of the post-crisis sort of recovery and reconstruction. You say that they're sort of artificial constructs in a way. But given your experience and looking at the post-Ebola crisis, what are the lessons that you've learned in terms of how, say, Liberia has recovered in after the Ebola crisis?
Yeah, I think it would go back to this, that the robust recovery, and I don't think even if you talk, Bernice can speak for herself, but I'm sure she would say that they haven't ticked all the boxes. They don't feel like they're sort of back to exactly where they would want to be, but it has been seen many aspects were successful. But I think the idea that the recovery plan had this link to their long-term health development plan. And so, we've said that countries, that preparedness, at least for us within health systems, is sort of a midway, a sort of a stopping point on the road towards universal health coverage. So, and I just spoke at a session. I hope none of you were there because now you're hearing me say some of the same things and it's probably boring, but that of health systems and health security, we used to talk about them completely separately, as if sort of IHR was like this separate capacity that people developed independent of the health workers that were actually in the field, as if people who were looking for the index case for Ebola, yellow fever, Lassa fever, et cetera, weren't during the peacetime delivering babies, fixing broken legs, et cetera. So every country that was at this recent Global Health Security Agenda meeting, every single country that presented talked about their primary care and community workers as the front line for their integrated disease surveillance system. So I think, Liberia, it's not perfect, but they have started to look at it that way. And also donors have, people have come around at least to talking about it that way. But I think there is still a separation because there's we need to bring those two communities together more at the country level, that we both from the donor community and from the organizations within the ministries of health. That in a lot of these countries they set up separate crisis centers that frequently report directly to the president and sort of bypass the minister, and then they end up setting up a lot of activities that duplicate. And that happened in Liberia, but they've started to integrate.
Okay. Great, thanks very much. Some really good perspectives to think about that, and particularly the word governance comes out within your remarks. So I'd like to go on to our next panelist, Samali Kitoleko. Have I got that sort of right? I hope so. Is a registered award-winning nurse from Uganda. And I would really like to ask you your perspective on working in harder environments, and particularly from the point of view of a frontline worker and their relationship with the community and building the trust and confidence that's needed in order to ensure that you can continue to give services.
Thank you. Thank you, panelists, and good afternoon to you all. I've been a nurse for the past 21 years, and currently I work in Uganda Heart Institute, and I take care of patients who have heart conditions, be it congenital or acquired. And most of my work is centered in the hospital, although I go to the communities to look out for those who have defaulted treatment. So from my experience, as I do my work, I encounter much of my patients being women and children. And as I do my work, I realize that these people need a lot of support from the health workers, and also need a lot of support from the communities where they live in, be it in schools, be it in their families. So I take responsibility to go down to the grassroots, to their communities, to the schools, the families, to ensure that these vulnerable people gain support from their communities.
Great, thank you very much. I think the insight that you bring there is when we're talking about health, we often think of it as health, but you brought in the community aspect of it, which is about it's a multidisciplinary approach. Could you tell us a little bit more about how you work with the education sector? That would be really helpful.
All right. So currently I work in the rheumatic heart disease registry, a disease which we know causes heart damage. It's common in children between 5 and 15 years. So when we are in the hospital, we see children and adults whose disease already progressed into severe form. So initially, that's what we were doing, only to see those who come to hospital when they are already needing surgery, which is not affordable by the common person. So we sat down and realized that that was not good enough, treating only those who come to the hospital. So what we did, we started screening programs. We go down to the schools, we make arrangements, and we just screen. We can select 3 classrooms, and we screen them for rheumatic heart disease. And then those whom we find that their valves have already been damaged, we initiate them into care. Then those who show that probably there are changes, but it doesn't look like the disease is confirmed, we keep them under surveillance. And even those who have started treatment, we initially start medical treatment, but when we see that there is need to do surgery, we forward them to the points of care for surgery. So basically screening to the school children and also taking the health education to the schools, because we see that this disease is common in children. Even though we have adults, like where I work, my youngest patient with rheumatic heart disease is 4 years, and then my oldest patient is 70 years. But it is well known that even this one who has the disease at 70 years, didn't develop at that age. Probably the patient got the disease in the 20s, 15 years of age, but it wasn't diagnosed. Because occasionally, many of the patients, by the time you see them to hospital, they've been battling with the disease for the past 10, 20 years, but it wasn't diagnosed. So that's why we went down to the schools to do the screening programs. And second, we are trying to involve the health sector, because we know rheumatic heart disease is commonly influenced by poor social factors like overcrowding. And when we look at the education system at our place, the classrooms are so congested, the dormitories are so congested, the structures are poorly ventilated. So we are trying to reach out also to the Ministry of Housing and Ministry of Health to ensure that the living conditions of children when they are at school does not favor the development of rheumatic heart disease.
Excellent, thank you very much. I think that's a really good example of different elements that we sometimes separate out. That is prevention, screening, and then treatment. And so often services are focused on the tertiary level without actually those linkage to the community and the broader community, that is education, housing. So thank you very much. That's an excellent example. And I'm sure others will have questions for you when we get to the questions and answers. So I'd like to move now to our next panelist, which is Jude Wakiki. Have I got that right, Jude? Ish, yeah, thank you. So Jude is Director of Promoting Quality Medicines at United States Pharmacopoeia. Jude has over 20 years' experience in pharmacovigilance and has, of course, worked for MSH for a number of those years. I have to put a plug in for the work you did with us, and has also worked at the FDA as well. And he actually leads USP's work in quality assurance for medicines and works in over 30 countries and has a team of over 50. So I would really like to ask you a question around how do you ensure in the more fragile settings that we work that you maintain the quality of medicines coming in?
All right, thank you very much, Catherine. And Thank you to my fellow panelists. I think this is an honor to be part of this group. We haven't gotten direct hands-on experience in places of crisis, but the closest is Liberia. Same Liberia, but not the same event that Ed has referred to, the Ebola, but just post-conflict. So Liberia happened to be the country we started working in 2009. Just when they got out of the crisis that almost decimated the country, and helped to work with them to set up the Liberian Medicines and Health Products Regulatory Agency. That was in 2010. So if you're talking about recovering country and recovery, I think that's where you begin to look at it. And talking about multiple crises. So that was crisis after the Civil War, and now the crisis of Ebola. But I think Liberia presents a very interesting case to highlight the work that USP through the PKM program has been doing. I think what is very exciting for me, particularly with regards to the work that we've done in Liberia, is that they moved on to become one of the regulatory agencies that I like to cite a lot. They have a functional quality control laboratory that has basic SOPs and conducts basic tests that are yet on their way to international accreditation. But with just that basic QC capability, they've been the one that have taken the highest number of regulatory action amongst all the other countries that we work in. 40 regulatory action just in 2016, and including effort they made to remove anti-malarials, quinine and amodiaquine from their market. So this is really something I wanted to mention to the Honorable Minister, but she isn't here yet. But we really are happy about the opportunity we've had to work with Liberia. But getting back to the rest of how we've been approaching this issue, particularly for recovering country, I think one thing that will help me to discuss that better would be to talk about two products or two conditions to choose maternal and newborn health. Why is that important? It's important because, childbirth is the most profound happy event that I can think of, and I guess most of us will agree. And when that ends in sadness, it's really bad. So you begin to think about things like postpartum hemorrhage, that is accounted for close to 20% of pregnancy-related deaths. That is the number one pregnancy-related death in Ethiopia. And you think about umbilical cord sepsis, killing thousands of newborns in Nigeria, in Pakistan. And when you look at those conditions, you begin to wonder, what else can we do in these countries that are recovering, as well as in countries that are recovered, seemingly. And I say seemingly because we all are familiar with how weak primary healthcare systems in some of these countries. So I will really venture to say that when you have weak primary healthcare systems, it seems not to matter so much whether you're recovering, post-conflict, reconstructing, and all that, because women and children will end up being very vulnerable. So it's one thing to recognize the problem. So we recognize the size of the problem of postpartum hemorrhage and umbilical cord infection. But I think the other thing is the fact that the global community went in addressing that. So the UN Commission on Life-Saving Commodities for Women and Children identified oxytocin and chlorhexidine as critical products among the 13 when the UN Commission was formed in 2012 that they wanted to work on. And, if you know these two products, you see that they are really a great opportunity to arrest postpartum hemorrhage for both prevention and treatment, right? So that women that deliver do not die out of excess bleeding post-childbirth. And then their newborn doesn't die out of this preventable infection, particularly when they deliver in away from health facility, as you see often in places of conflict. So you might ask, what's going on with these two products? Are they not very simple, old, generic products? Why is it that it's not readily available? and not being used even in conflict situations? And that would be a good question to ask. And there's supposed to be more than 500 people that manufacture oxytocin, for instance. But what we do know is that they are manufacturing it, but guess what? The quality is an issue. So there's a systematic review, one of the few we find in our field, and everybody in USP will tell you that, of really trying to understand the size of this problem. So this systematic review was an effort to do that, pulling together several discrete studies to look at synthesizing the size of poor quality oxytocin. So out of 559 of those, they found 76.1% failure of oxytocin that we give to our mothers during active management of third stage of labor. It's very, very concerning. And other studies have, repeated this. They have gotten similar numbers. In fact, the most recent, 2016, from the WHO, looking at supporting the UN Commission's work. So they looked at several products and focusing on oxytocin again, they got 64% failure. So, but that provides an opportunity on itself. Because when you take a product like oxytocin, it seems to be one that can tell you a lot about resilience of health systems, how the quality assurance system is robust enough to withstand crises and conflicts. Why do I say that? It's a parenteral preparation. It's time and temperature sensitive. So what that means is that pre-approval and inspection capacity of the regulatory agencies or quality assurance system authorities in your countries, if they are doing their job very well, they will be able to pick up when you have oxytocin that has a problem. And because it's time and temperature sensitive, if they have a robust post-marketing surveillance, they will be able to ensure that the transport and storage of this medicine is done very well. So we are doing something about this. So I work with United States Pharmacopoeia on the Promoting Quality of Medicines program, which is funded by United States Agency for International Development. And we are looking at these systemic issues that are impacting on access to medicine, particularly when you're thinking about women and children that are most vulnerable. We try to help these countries to build up their system so that they can resist some of these obstacles that seem to repeatedly happen. And, I finished with two examples of how the PQM program has done this. So if you take oxytocin, for instance, out of these 559, out of these 500 plus manufacturers that I mentioned, if you take a country like Nigeria, that have 36 oxytocin approved by their regulatory agency, none of them is a local manufacturer. So when products are made from outside, it's good. It's a good thing because ultimately what we're interested in is access. But keep in mind that importation provides additional challenge to weak and not too resilient regulatory agencies. So if you have an opportunity to take the production of this medicine closest to the burden of the disease, particularly in environments where it's economically feasible to make those medicines, that's something you should be doing. So in Nigeria, we are supporting a manufacturer to attain international good manufacturing practice standards to be able to make oxytocin that will be used with their population. And we are doing similar thing across multiple other countries. For clohexidine, we have an amazing success there, one that I was discussing with NASA. I didn't know he's been very well connected with the work we do. So this simple gel that's supposed to be rubbed on the umbilical cord to prevent infection has not been registered in many countries. So when the reproductive and maternal child health survey was conducted, some of you may be familiar with that, they found that oxytocin had one country registering it as 2012. For clohexidine, none. And the WHO just have one clohexidine that is pre-qualified from GSK. So very simple product, but it's not readily available. So what we're doing is working with Pakistan to make this product. So just a few weeks back, we got 3 Pakistani companies that have now been approved by DRAP, which is their local regulatory authority, to manufacture this clohexidine gel. this is the very first time that that country is going to get this medicine readily available for its population as well as to export. In Nigeria, the chlorhexidine that the PKM program supported to manufacture was used. It was very handy in getting to replace a product that was donated that was causing or supposed to be connected with irreversible blindness in children. So we have a manufacturer that had been approved by the local authorities there and was able to distribute this medicine, not just within their country, but as far away as Haiti. So I think this is one of the ways of looking at this. Issues of quality of medicine is critical. It's front and center because women may continue to have babies during conflicts, post-conflict. And I think we need to do all we can to make sure that these basic medicine they use are quality assured. I would love to discuss with the rest of the panelists and all of you on your experiences as well. Thank you.
Okay, thank you very much, Jude. So I think that going back to something that Ed said, that often we think of countries in crisis, post-crisis recovery, and we put it in this artificial, if you like, segmentation. But what you're saying is that often countries never can not sometimes get out of that post-crisis situation enough to ensure that they have good quality medicines and that during normal times. I just want to reflect on something you said as well. We talked a little bit today at session earlier about Every Woman, Every Child. And for those of you who know the Every Woman, Every Child initiative will know that one of the initiatives that came out of that was the UN Commission on Life-Saving Commodities, just to put this in context, which began in 2012. And they looked at 13 actual life-saving commodities over that time. Chlorhexidine and oxytocin were two of them. Just to reflect also, when we heard that oxytocin in many situations, over 76% of those situations, were actually not effective, people said, oh, well, then we'll go to misoprostol. And then they did tests on misoprostol, which is another drug for postpartum hemorrhage, and found that that was also degrading because many of the packaging that was actually protecting the drug was substandard. So, we have to think across the board of standards of medicines. And just a personal anecdote, often when I've been in different countries over the years, and I've talked to nurses, midwives and physicians around oxytocin as being a really effective drug to prevent and treat postpartum hemorrhage, they've said, but it doesn't work. And I used to scratch my head and say, well, of course it works. Yeah, of course it works. It was very effective. But not if 76% of the drugs in the market have no potency. Of course it's not going to work. And so it's really thinking of the situation where you have got somebody who is bleeding, and no matter what you do is you think you're giving them the right substance and it's not working. That's a very frightening situation for any frontline health worker. So thanks very much, Jude. So I'd like to turn to our last panelist, but last but not least, and I'm going to get this wrong as well, Noza Orobaton, who's the Deputy Director for Maternal Child Health at the Gates Foundation. And he is a medical physician with many years of postgraduate experience, including in business management. And previous to working at the Gates Foundation as the Deputy Director, he's worked at both WHO and the Global Fund. So really a broad experience of many of the situations that we're talking about today. So I would like to ask you, from your perspective as a donor, what is the role of the donor community in supporting countries who are coming out of crisis?
Thank you very much. What I would do is to sort of approach. Oh, it's okay. It's better now. Yeah, thank you. In preparing for my remarks, there were a number of things that struck me. The first is just what is it that we mean by resilience? So just to be on the same page. So I resorted to the Oxford Dictionary of English, and it talks about the capacity to recover quickly from difficulties, but it doesn't talk about the chronicity of difficulties and how long it takes. But it alludes to the idea of toughness. It also talks about the ability of a substance or object to spring back into shape, implying elasticity, flexibility, pliability. So when you start to think about these dimensions of what resilience stands for, and then you look at according to the flyer here, how do we leverage the power of the Sustainable Development Goals? And if you look at the SDG, I mean, a number of elements stand out. One is the interconnectedness between the various goals. You can't really do one at the expense of the other. We have to do them concurrently. The idea of partnerships, the explicit focus on inequality, and very, very important, a focus on innovation. So when you put these two sets of considerations in mind and you ask the question, how do we systematically increase the odds of countries strengthening their health systems, in terms of addressing vulnerability to mothers and to children, and bearing in mind, as Ed has just mentioned, this idea of vulnerability or fragility, in most of these settings, they are chronic in nature. It's hard to tell what came first. Is it the chicken or the egg? But really, the idea is that there's an underlying narrative in many of these settings that require not just a fix, stepping, going and fix, but really a systematic approach about how we engage these things. So with these considerations in mind, at least from the perspective of the Gates Foundation and also a number of donors, Canada, Norway, and a host of that, and the private sector as well, Merck for Mothers. The instrument that comes to mind that is gaining a lot of play is the Global Financing Facility, which, is an invention of the former Secretary General as the financing arm to drive reproductive health, maternal health, child health, newborn health, family planning, nutrition, etc., in the context of every woman, every child. And this is actually quite germane because we do have unfinished business for the previous MDG 4 and 5. So what is it that is unique about the Global Financing Facility? The annual report, first report was just issued this morning. So those of you, if you're interested, I suspect you can find it on the website. And in terms of what is unique and what is different about the Global Financing Facility, and I asked this question also from the perspective of having worked extensively at the Global Fund, where we had country mechanisms, also considerable familiarity with the Gavi. I think a critical element is the GFF's ability to empower countries, to bring stakeholders together, to identify priorities based on evidence. And the second is to also, in this context, provide financing to address these problems. And what is unique about the financing is the idea of tapping domestic resources, countries' own resources, in a variety of ways, soft, hidden, and so on and so forth. But also finding ways to increase the efficiency of the existing funds that are at hand. And then thirdly, those external donors and partners that have resources to align their financing and funding around those sets of priorities that the country has determined to be what needs to be done and how we need to proceed. So as a consequence of this process, which is really a way to help countries to systematically cultivate a set of discipline of identifying priorities and moving things forward, you find out of that, the whole notion of resilience begins to gain attraction. So some of the things that we've seen already that are emerging is that the underserved and the underfinanced areas are increasingly coming out as top priorities for a variety of countries. Sexual reproductive health and rights, nutrition, newborn and child care, and adolescent care have come out increasingly as primary areas of focus. And then the other distinct element is the focus on a recognition on fragility. There are currently 16 countries that are in the global financing facility that receive support from the GFF: Bangladesh, Nigeria, Cameroon, the Democratic Republic of Congo, Vietnam, and Guatemala, to name a few. But what is very interesting about this is that of these 16, 4 of these countries are classified as fragile. One of them is post-Ebola. And then 3 of those countries have identified sub-regions in their countries as to the areas of as areas that require primary focus and attention. So in effect, 8 out of 16 countries have identified issues of fragility and as areas that they want to systematically make investments in. So this is one of the elements that really makes for the GFF as a compelling proposition for systematic investment to help us to begin to help countries to be more durable and to be more good. So I would just cite Cameroon as one example. 87%. Oh.
Did it go off?
Back.
Mine went on. Sorry.
Okay. 87% of the poor are rural-based, and in Cameroon, they're mostly concentrated in 3 regions: the far north, the northern region, and a place called Adamawa. And in addition to the poverty, they've also been struck by the effects of Boko Haram and so on and so forth. Again, this notion of which came first, is it the conflict or is it the poverty, and so on and so forth. But regardless, the idea of building resilience needs to take force. So UNICEF, as a key partner, brought together, used a tool called the EQUIST, which is really sensitive in identifying geographic inequities, identifying areas that needs to be, for which interventions need to be sought. Partnerships were developed at the national level by the Minister of Health, Ministry of Finance, cross ministries, and they identified one example of a problem, that is the issue of adolescents. Fertility rates are high, school completion rates are low, and then the vicious cycle that comes out of that. Because of this approach, Cameroon decided to work between the Ministries of Finance, the Ministry of Health, and the Ministry of Education to develop conditional cash transfers, which will keep girls in school, have them get as much education as needed, but also delay the process of having babies. This is one example of how the GFF is on a systematic basis can actually help countries to begin to identify the specific and the issues that need to be addressed and how to move forward with them. So just stepping back for 1 second, and I'll be done. What are some of the key insights that we think are linked to the process of the GFF? The first and foremost is ownership. Without ownership, there's very little that can be accomplished on a durable, and sustained basis. So that's one element. Then the second, which is the idea of measurement, and not just measurement for its sake, but really measurement that is intentional in straddling the technical space alongside with the political space. If you have measurements that results in technical people talking to technical people, we have lost the game. We need to have technical data in the political space to drive a number of this, to drive this forward. And I was involved in some of this kind of work in Uganda about 12 years ago, and I'll be happy to shed some light on that in the Q&A session. And then the third element is the idea of partnerships, not for its sake, but partnerships for results. And in that context, I was involved in working on a public-to-private partnership, work in Nigeria that actually led to moving clohexidine production in Nigeria from 0 in 2012 to 120 million units per year in 2016. Thank you.
Yep. Thank you very much, Nusa. That was a very good overview of a global facility that can support countries that are in recovery phase. Can I ask, would a country be able to apply for these funds at a time of crisis to help with the recovery, or what sort of criteria does the GFF sort of put around a country's application for these funds?
Well, as part of the GFF, there are actually a number of specific countries that were named in the Every Woman, Every Child as priority countries. So those are the main priority countries. But aside from those countries, the GFF Investors Group has recently had conversations about how do we perhaps find ways to draw attention to some of these countries that are in states of crisis. But having said so, the 62 countries that are part of the GFF, many of them are laden with the kinds of conflict and fragility that we are talking about here.
I've realised that once one is on, another one is off. That's the trick to the microphones. Can I have one follow-up question? The follow-up question I would like to ask is, and it came up yesterday in a panel, I think it was Beth was talking about it yesterday, that sometimes these funds that are earmarked for particular areas, it's really difficult to know how to ensure that the systems that are required to actually support the interventions are funded. So does the GFF allow for system strengthening in terms of its funding, or is it specifically earmarked for a particular intervention?
One of the defining qualities or attributes of the GFF is that it is not earmarked. And at the heart of the GFF is really about helping countries to strengthen their health systems. Without health systems that are strengthened, it's actually very difficult to assure the kinds of results that we're looking for.
Sorry, I put you on the spot for a couple of questions. So what I'd like to do, I'd like to turn it over to the audience now to ask some questions. I think Aaron's got his hand up already, so we'll take questions. And what we will do is we'll take 2 or 3 questions, and then we'll turn it over to the panel for another set of questions. So I saw Aaron's hand up first. Is there do we have a microphone?
Except for people in the back. So people at tables have mics.
Is there Aaron, could you? That would be great. I think there's also a mic here. Crystal, if we can have a couple of folks doing roving mics, that would be great.
Thank you very much. My name is Aaron Emma from the American Academy of Pediatrics. This was an excellent panel. My question is about brain development, which happens to be taking place really at the time that you're speaking about, from gestation through age 5 is when the brain is really growing a lot, and the impacts of prolonged repeated stress, such as through crises, on the brain can lead to lifelong debilities in cognition, in socio-emotional health, and in lifelong physical health. And one of the ways to prevent that is through sustained adult relationships and through other types of continuity in the child's life. And so I'm wondering, in the strategies and plans for disasters that are taking place in the different countries in which you work, to what extent are the health workers working with other caregivers to make sure that there is continuity in children's life? Thank you.
Great, so that's early childhood development. I'll take a question from the back.
My name is Adris Malata. I'm Vice President for International Confederation of Midwives, but I'm also a midwife from Malawi. So my observation, particularly on the presentation on quality of medicine, so the presentations were excellent, but this particular presentation struck me so much because I'm thinking of a midwife who is in a rural area. And here are medicines that are being utilized in that area that perhaps could not be potent. How much awareness is there about this issue, particularly for those people that are on the ground and many times are blamed if women die? Do they know that perhaps it could actually be quality of medicines? Thank you.
That's a great question, and we'll keep that question. I saw a couple of hands over here, and then I'll come back over.
Thank you very much. My name is Michelle Farmer. I'm with NCD Child and the American Academy of Pediatrics. I had a question about sustainability and workforce development, particularly hearing about increased local manufacturing of medications, which is particularly strong. But I'm also thinking about this as an opportunity for equity in terms of development of industry and having gender equity in terms of development of the workforce, not just at the level of the healthcare provider, but the manufacturers. So I was wondering if someone could shed some light on how, as we are building through GFF, to have some equity and of opportunity for women in sustainability and also for youth in terms of developing a sustainable workforce in these areas. Thank you.
Great, thank you. So a question about gender and workforce, and I'll take one more question here.
Thank you. I think this is working. Hi, I'm Laura Henneke from Intro Health International. Okay. Good afternoon, Laura Hemmeke with Intro Health International. Thank you to all the panelists. They were really interesting that it was 4 very different perspectives, but I think I'm trying to see the link among the 4, which is fascinating to me. Having worked in post-conflict countries myself, I think one of the challenges is, as Ed and others referred to, is I think there's a lot of underestimation about how long it takes to recover, whether it's from a conflict or a natural disaster or an outbreak like Ebola. And so as a result, when an emergency is happening, a lot of aid is pouring in. And then as soon as the global community sort of thinks that the emergency or the conflict or the disaster is over, it often goes out pretty quickly. And yet, speaking specifically of Rwanda, even looking more than 10 years after the genocide and war ended, the health system was still in shambles and needed a lot of work. The health policies hadn't been updated, et cetera, et cetera. So I'd just like your perspective on how we can avoid that. And I think it goes back again to what Ed said. It's a cycle of sort of response to recovery to resilience, but it's almost like a cycle rather than just a straight line that needs to continue. Thank you.
That was a great question. Great, so we'll We'll go to the panelists to answer the first round of questions, and then hopefully we'll have time for another round. So, Aaron talks about early childhood development and really the first 1,000 days and even up to 5 years when brain development and other developmental milestones are raised. So, how do we ensure that there's this continuity of care and that we can ensure that we have good childhood development?
Thank you very much for the question on early childhood development, brain development. In fact, one of the areas that is actually of particular focus and attention for the Global Financing Facility and the World Bank and the Africa Development Bank is really about, as they say, building the gray matter, infrastructure, and looking at the health aspects of cognitive development. Good antenatal care, mothers getting their supplements, the child being delivered, and the use of kangaroo mother care. There are a number of micro interventions that, if done in concert and is done systematically, can actually be helped to be scaled up. One example is Cameroon, which I did not mention. They're using their investment in the GFF they're using a bond process to actually invest in KMC to scale up KMC. It's never been done before, but that idea is actually being looked at. So the idea of nutrition and all those things are really very very important, and the lenses are really on early cognitive development, to address those things now, rather than later. Thank you.
May I just follow up on that as well, unless any of the other panelists want to comment? No? So early childhood development, I think, is a really critical area, and until fairly recently has not been an area that's been funded. But UNICEF has taken this on as an area, and also the Hilton Foundation has been funding work on early childhood development 0 to 2 years with partners like PATH, Save the Children, and there's been some really innovative work happening in Mozambique, South Africa and Kenya around this issue, and particularly around working on the relationship between the adult in a child's life and the child around issues around bonding, play, stimulation, and how the interaction between the parent or the grandparent or the carer, the guardian and the child. So I think it's really a critical area of development, and one that hasn't received a lot of publicity and emphasis, but now is definitely. So it's a good question. Thanks, Emma.
Can I make a quick comment on that? Just I think that this is one of the, and actually probably somebody would be the one uniquely qualified as the one seeing children actively of all of us up on stage right now. But I think this points to the difficulty too. You made a reference to the need for different types of providers for in early childhood development, but also through the life course. WHO has an approach on service delivery and service structure that is really around now versus last year at the World Health Assembly, where we adopted a new framework on integrated people-centered health services that is really focused around people and around the life course. And the difficulty is and it really calls for reorganizing the workforce around one, kind of impaneled patients and communities. So you take care of a group of people. You don't take care of a disease when it walks through the door. And then two, that you're organized in teams of providers. But yeah, that can only be done obviously when you actually have a team of trained medical professionals. So there's a lot of discussion around the health workforce strategy that was also adopted last year around task shifting and how you can manage some of those things. So I think those are important things. And so I notice a few of you on your phones. The first round is over.
Oh yes.
Dr. Tedros was first, David was second, and Sonia Nishtar was third. in that round. So the second round starts with just those two. So I thought I would let you know in case people, then you can put your phones down now.
Okay, thanks very much, Ed, for that update. There's an air of excitement and anticipation in the room, which is great, not just for the panels and the speakers, but for outside events as well. So I'd like to go to the second question from the president of the ICM at the back, when she talks about rural health workers and whether they're aware of the issues around the quality of medicines. So, Jude, do you want to take that one?
Right. Well, I think that's a very interesting question. That's a very good one. And indeed, even the subsequent question related one way or the other, they are both addressing issues of quality or manufacturing. So if I may take both of them concurrently. But I think I wanted to ask how long we've got.
Well, actually,
no, I'm kidding.
We have time, don't worry.
I think this is a topic that is topmost. So sorry. I think it's a topic that is topmost on everybody's mind in terms of how does the frontline healthcare provider, how much aware are they about the quality of the product that they're using? What index of suspicion do they have? Or do they behave just much like the uninformed buyer that the consumer is? So that information asymmetry may still be there with even the trained healthcare provider, and that's not unexpected because we're talking about products that you cannot make out just by looking at them that they have poor quality, except if you have a parenteral preparation that has a particulate matter or that changed color, then you may begin to raise some suspicion. But I think the point being is very important that we raise the awareness about it. So how are we doing that? So some of these surveys, quality audits on oxytocin, we tend to want to insist that countries need to publish them when they finish. Or first, they have to use a standard protocol to make sure that the sampling and all that are done very well. They are representative. If you want to think about this as a show of the rate or the prevalence of poor quality medicine in that country, in this instance, oxytocin. And then we have to make sure that the tests are conducted in accredited laboratories, so that the results are reliable. So, but after that, you have to publish the results. You have to make sure that the frontline healthcare providers are aware of the size of the problem. So the local regulatory authorities can help in this instance, but as well as just involving those people that often are not thought of working in the area of quality of medicine, those doing BCC work and all the rest of them. But I think one other point to make there is that the OBGYNs and the midwives are front and center in this, because they, at times, some of them, we've encouraged some of them to do a clinical audit, of these versions and brands, generic oxytocin that you're using. How many of them do you use before you control bleeding, for instance, post delivery? So we are trying to do that in a couple of countries. In Ethiopia, we're about collaborating with Monash University to really look at oxytocin, not just doing the quality audit, but look at all aspects of how it's managed, how it's distributed. But I'm really thrilled that you brought that question up. As a midwife, I think there's a role, right, in ensuring that understanding of the impact of the temperature on the product. This is a peptide hormone, right? It's easily degraded once exposed beyond the temperature that is recommended for it. So I think when we don't just over-rely on the inspectors from the regulatory agencies, but as a midwife, being conscious of that in the health facility, and indeed this product is indicated for use at health facility. So making sure that last mile that is stored at the right condition, but supporting the efforts to also ensure that the pharmacies, the shops that are selling these products are encouraged to store them at the right condition. So there's a lot that can be discussed around that, but it's just something that shouldn't be happening, that we have such, extent of failure of a product that is so important for an event that is supposed to be very, very happy. So can I take the manufacturing very quickly? So I think thanks to USAID, we are required to report on gender equity. So when we submit our reports, we talk about the number of people that are trained, males and female. And we're increasingly seeing more and more females being trained in areas like quality control, lab analytical work, working in the laboratories that analyze the quality of these medicines. But something that is interesting for me particularly is that as we work with manufacturers that make these products, it may be surprising to you to find out that those that actually pull the plugs in some of those manufacturing companies that are family owned, the spouses of the CEO. So the manufacturer that we are working with, one of the manufacturers we are working with in Pakistan is really, the person that takes this decision and all that is a woman. In Nigeria, where we're trying to get the first locally manufactured oxytocin out, is the wife of the CEO that is driving all this. So I think increasingly we're beginning to see, not just being in the shadow of their husband, but we're also beginning to see a lot of women venturing into this area of manufacturing. And then when you go to the regulatory authorities, of course, most of the inspectors and the toughest regulators are women. Yeah.
Great, thank you very much. And I think we had one more question before I go to the next round, which was around the length of recovery from crisis, the length of time it takes to get from a crisis to recovery. And what are the key elements that define that length of time? So I don't know, Ed, would you like to take it?
Yeah, I think also there was the point about, the situation changes quick. I think this is related to a lot of things, but it's partially related to the ridiculously short attention span that all of us have, and it's getting increased. I can tell you the future generation, based on my own daughters, it's getting shorter. But I think that also with the news cycle being what it is, and the difficulty around ensuring positive stories on global health, are not really so newsworthy. If you look at the Ebola crisis, for instance, in DRC, and others may want to comment on this, but there's things have been managed quite a bit better. It's obviously a lot smaller than the other bits were, but the other crisis was last that we had in the three countries, but that's also just not quite as big a story to talk about in the media, to talk about how the international community really came through. So you could see it even on, for instance, on Ebola, working closely as I do with the U.S. administration and CDC, it had major shifts on their committed funding on Ebola immediately to Zika. There was no new funding that was provided, even though there were big commitments made on Zika. And we could even link this back to our question on early childhood development. But a lot of the commitments that were needed to be made were in some of the countries affected, Brazil in particular, but other countries, was around longer-term needs of these babies and the families that were dealing with this. And so those kind of fall outside the security earmarked funding that was made there. So I think there's a whole bunch of things that are playing into that. But in terms of the key factors that where certain countries are able to move quicker, I think being able to leverage, we should be honest, being able to leverage other resources. Nosa mentioned this earlier, but Nigeria moved very quickly and moved on recovery afterwards on Ebola because it was able to repurpose polio assets and these and other assets that were there. So there are strengths of each of these health systems that they can move on, but there needs to be sort of the ability to do that and a policy set up for it. And I think probably really one of the it's not the only thorny issue, but one of the thorniest issues that countries face on the move from response to recovery is how you handle because you almost always mobilize a big bunch of people to do some stuff for you, and how you transition them to either back into their regular roles or onto the regular books of the Ministry of Health or Ministry of Education, if it happens to be that, because that's not easy to do, because you have to create extra fiscal space, and there has to be big negotiations at quite a high level for those types of things. So practice with that, and I think some of the lessons that have come out of Ebola have been that the health agencies need to be working with the global financial institutions in order to make those cost it out and make it happen.
Great, thanks very much. Nusrat, you want to?
Yeah, just the thing for me, just to respond to Laura's question is, I think it's really important for us to not lose sight of the fact that many of our health systems have been chronically underserved and chronically underfinanced, and what we now characterize as an event, is really a manifestation of something much more profound. So I think that it's good that we're paying attention to some of this crisis, but I think what really is important is how we ask the fundamental questions about: are we providing sufficient financing to address? Are we doing that? Are we financing the right things, and are we going about them in the right way? These are questions, if properly answered, basically unleash the potential power of communities, of states and countries to actually to be more resilient. So I think it is really important that we ask this fundamental. Otherwise, we're going to find ourselves collectively, not doing the right things.
Okay, great. Thanks very much. I think we've got time for two more questions only, and then I want to go to our closing remarks from Dr. Rupert Dahn. Oh, gosh, I've got 6 hands, not 2, but I do know that the first 2 hands, yeah.
Thank you very much. My name is Lisa Hilme from Core Group. I'm very excited that you have a nurse on the panel and the community voice. I think that's very important in this dialogue. And so my question is for Somali. And Somali, there's a lot of discussion around community scorecards, accountability for quality. And we've heard about quality of medicine. But I'm interested in Mitana, or in other areas in Uganda. Do they have these community scorecards for either holding the government accountable to the healthcare quality or healthcare workers? And how do you feel about that as a nurse?
Thank you for that question. As I said, I work in the rheumatic heart disease registry, and we ensure that most of the drugs we give our patients are supplied from the hospital. The biggest challenge among the drugs we give them has been benzathine penicillin. I think many of you ever got that injection. It's very, very painful, and these patients get it every month. And we've had challenges where patients report that when I go for my injection, the nurse has to prick me 7 times before that drug can go in, or as you're trying to dilute it, it splashes all over, even into your face and on your clothes. So we've come across such reports from patients when they get that injection outside there. So what we've done at my place of work, we ensure that patients get drugs from us. We get the drugs from the Ministry of Health under the National Medical Stores. They supply us with the drugs. And we ensure that, because our patients are supposed to come to hospital every after 3 months, so when they come to us, we give them drugs of 3 months, such that we ensure that during that period, they are getting the drugs we gave them. But normally when they come back to us, there is a survey form we fill on, like, for instance, that injection. We ask them, since they left the previous visit, how many injections have they missed, and what is the reason that they missed. Some of them will tell you that it was the previous injection was very, very painful, or the injection failed, so I didn't go back. Then we try to ask them if they have any remaining type of that very drug that failed, and then they bring it back to us. So when they bring it back to us, we try to cross-check the batch numbers, whether they match with that, what we have. And if they look totally different, then we can say probably that is not a good batch. But I was given a task myself to try and look backwards into all the batches we've had and try to establish if there is any particular batch that I felt was giving me trouble. And I've been able to do that. And what we are going to do is to ask the Ministry of Health to work with national medical stores to give us a particular batch, which from experience I've realized that doesn't give me problems. It is not so thick. You can easily dilute it. You can easily give the injection to the patient without a lot of trouble, without having to prick the patient several times because the drug doesn't go. It has blocked the needle. So basically, that's what we've tried to do. We are keen on it, on the drugs and the sun rays.
Great, thank you very much. I think that's a really great example of where a health worker is actually doing, as you said, Jude, and maybe you want to comment on this, a sort of clinical audit around drug quality.
Right. Really very wonderful work, and the approach that you've presented seems to me that that's the way it should be done. But what I wanted to add is that point of encountering a product that seemed not to be working for whatever suspicion that is, becomes a golden moment to really suspect this product, send it to the National Quality Control Laboratory and request that quality test should be done on it. So I think the frontline worker, in a sense, is really positioned to do that the best. That's at the point we started talking about this whole idea about democratization of inspection. In other words, don't rely only on your national regulatory authorities inspector to show up from the national capital and come to your region, to the rural health facility, to sample products blindly, products that they don't know whether it's been stored correctly or it's not been stored very well. So, but when we have everybody raising that suspicion and being a champion for the quality of medicine, you could direct the use of that regulatory resource, so that instead of going all over the country trying to pick products and test, they can go to a specific place. They can, pay the attention to the products that you have suspected that there may be something, there may be an issue with them in terms of their quality. Yep.
Thanks. And I know Naza wants to comment.
Just a listen to your question about community scorecards. In some of the work that I was involved with in northern Nigeria, in Sokoto State, which is in the northwest, the sulfadoxine pyrimethamine is used for presumptive treatment of malaria in pregnancy, and it protects the mother and the baby in a variety of ways. WHO requires three doses, at least 3 doses. In Sokoto State, 1% of all the pregnant women had 3 doses. So we decided to do something about that, and we focused on 3 local governments, and these medicines are universally available. There's no stock out anywhere. So one of the key elements there was communities at what we call the Ward Development Committee. They held regular meetings with the local government, asking them to provide them with monthly updates and why was this moving, why was that moving, and so on and so forth. And over a course of 6 months, the proportion of women who got 1 dose went up to 95%, and who got 2 doses went up to 75%, and who got 3 doses went up to 41%. The community aspect was in terms of asking, not just scorecards in writing, but using the oral tradition and demand accountability was a critical reason for such improvements. Yeah.
Great, thanks. I'm going to take one last question, the gentleman at the back who's had his hand up, and then we must wrap up and go for our closing remarks. Thanks.
Hello? Is this on?
Yes, it's on.
Great. Hi, I'm Derek Treatman from Vital Wave. I wanted to ask a question of all the panelists, but in particular, Somali, I was interested in your response on this one. I was wondering if you could share any of the low-cost innovations that you have seen to have had the greatest impact on service delivery or the capacity of frontline health workers?
Okay, thank you for that question. So particularly where I work, I'll put much emphasis on rheumatoid disease because that's what I do every day. That's what I know best right now, although I'm a general nurse. I can deliver a mother, by the way. I did midwifery, but right now my emphasis is in rheumatoid disease. So what we've done in our hospital, we've ensured that all patients with rheumatoid disease, by the way, I work in a government hospital, but the institute itself is autonomous, meaning that all services are paid for. So when we realized that many patients are not coming to hospital because they cannot afford to pay for the consultation fee, then those ones who are taking the anticoagulation are not able to monitor their INRs, we came up with measures of seeing how best we can help them. One of the things we did is that we waived them of the consultation fee, so all those patients don't pay consultation fee. And the cash office is very aware of that, and on many occasions they even give me calls to ask me that so and so has been sent here to pay money, but he has this card. Does it mean that he doesn't pay? Then I go ahead to say that yes, he doesn't pay. And if by any chance they pay and yet they are not supposed to pay, I have the right to endorse on their receipt so that their money is refunded so that that money can be used for something else. So that's one step we took. Another step we took for patients who are taking anticoagulation, they were taking a lot of time in the hospital waiting for their blood to be drawn, to have the blood sent to the lab to check their INR. It takes time and it's quite expensive. So what we did, we got point of care machines, and we charge a very little sum of money, which is just a user fee. And for those who cannot afford it, we go ahead and do it free of charge. You get the results in 2 minutes. So it kind of reduced on the time the patient stays in the hospital as well as on the cost. And the drugs, we ensure that we give them a good supply, but at least not more than 3 months because we are not sure of how well they're going to keep the drugs at home. So the maximum we can give them is 3 months, and we ensure that we supply those drugs because we pushed the government to supply those drugs under the basic drugs needed in the hospitals. So basically that's what we've tried to do to ensure that all patients get standard treatment.
Great. I think that's, thanks. I think those are great examples of both the technological advance in point of care, but also the advocacy that you're doing as a frontline health worker, and also looking at ways to provide longer term therapy for people that they don't have to keep coming back to the health facility all the time. So that's really great. So I'd like to go now to our closing remarks, and I'd like to invite up Dr. Roper Dahn, who's the director and co-founder of the Women in Global Health. And she is not only a medical doctor, but an advocate, and is working to really hard on looking at the gender equity issues that did come up today, of course, in the panel. So I'd like to personally thank the panelists for answering their questions and making remarks, really great remarks. But I am glad I'm not giving closing remarks because there's a lot to think about. So over to you, Roper.
Great, thank you. So the suspense is building. So it's really a privilege to be able to talk to all of you on an area which really matters to our organization, to our community in global health. Like, how do we really build resilience? How do we strengthen? How do we make our health systems responsive? And really, I think core to this discussions today, there's a lot of mention about community. But I wanted us to take a moment to think about, when is this opportunity really taking place? So post-crisis is a chance to hit the reset button. It's a chance where we can say, okay, we realize that there's an issue and there's an opportunity to go in, respond, recover. And as one of our panelists said, this is the time to unleash the power. And the title of our session today has been Against All Odds. But I challenge us to think about, how about this being the best of all odds to build a health system? A responsive, resilient system for all. So thinking a little bit more about the word build, I tried to pick some themes that I heard our panelists speak about today, and those of you from the audience that raised really valuable points. Build begins with bringing the community. We really have to think about how all the community members can be a part of this, not just from the beginning of when we have to provide an intervention. We heard the importance of prevention, but I would say let's challenge even from the design part, from analysis, design, implementation, evaluation, circling back. They have to be core from the beginning. Then we also talked about uniting. There are a lot of partners that enter the environment, especially post-crisis, post-conflict. It's about partnership building at every level, across sectors, across multilateral agencies, across even the community health workers themselves. So really thinking about that as a way moving forward. And then there was a message that it's not just about any partnership, but it's about partnerships with results and actually monitoring, tracking, reporting back, sharing the stories of great partnerships. I heard a lot about integration, thinking about the health systems, resilience and response, not only as a post-conflict response setting, but thinking about the fact that there are already existing health systems. Primary health care exists, community health care workers exist, other health workers, health professionals, they're there. They're often underfinanced. The systems are already weak. And when we have to think about building them, factor that in because they're the first ones already working there and know the setting. So think about integration at every level. And then an aspect which really stands out is about leadership. We all have an opportunity for leadership. As the suspense in the room builds, we're thinking about leadership. And we talked about that the groups that are coming in, they are coming in with a leadership, and the groups that are in the community have a responsibility too. So not only think about investing immediately, but really thinking about investing with a long-term impact. And what's really valuable about the discussions that we had today is that there's a lot of dissemination of knowledge that happens this particular week, dissemination here in this room. But let's think about how can we make this dissemination go much beyond the room. We're really fortunate to have Somali here join us, but there's many other community workers, health professionals, leaders of health systems, other sectors that don't know about these good practices or the challenges or the tools or the measurements. So let's really think about how we can disseminate the information a lot better. So again, building the sector, building the health system, we really have to think about building with all actors. And for that it means, sorry, just bending over a bit with this. But what that means to me and to our organization and to many of the people is that the health system is comprised, 75% of it, the health workers are women. So if we don't think about the gender dimension, we're really missing a key component. Yes, gender is socially constructed, but we have so much evidence showing that gender impacts health. And if we don't factor that in, then the type of solutions we're making, even before that, when we're defining problems, we're missing the picture. So we have to apply a gender lens at every aspect, from the leadership style to the programming design to the way that we actually measure, report back, because that's core. These are the people on the ground and the communities they're serving, the vulnerable population that we talked about. So gender is, as I often say, cross-cutting. And without this, our results are going to fail. And so we have an opportunity, again, instead of against all odds, let's think of this best of all odds. It's a chance to reset. We've heard case studies from countries, especially looking at the case study of Rwanda or Liberia, post-conflict settings. They've had some of the most responsive, gender equal, gender transformative leadership as a result of using that opportunity. So I encourage us, when we do get this chance, let's make sure we do keep gender on the board. So a few days ago, we had the chance as Women in Global Health to co-host a dinner with GE using a partnership model to celebrate heroines of health. And Somali is one of our heroines of health. We wanted to bring these women that are working on the toughest health issues locally in their communities to really showcase that linkage of local to national to regional really matters. And we're very fortunate to have that voice here. And at that particular dinner, we were able to gather all the next DG candidates, and they all made strong commitments to gender equality. So as we challenged them and we challenged our dinner attendees, and my challenge to everyone in this room, and I hope that all of you will join in joining our call to commitments for gender equality. There's 5 simple ways that all of us can advance gender equality. The first, it begins with visibility, recognizing women's contribution, but also recognizing in this decade of he for she, as we know 4 of the UN agencies are headed by women, and most likely this number will change. So let's think about how we can think about gender equality as everyone's thing. Think about visibility for women leaders, but visibility for men who are also champions, and also the other genders that are not represented. The second thing is thinking about thought leadership. We all have communities we belong to. We can begin the dialogue locally. Again, a theme of building. Think about also the data aspect. We heard a lot about dissemination of information and tools. There's a huge gender data gap that we've heard about. All of us have an opportunity to think about reporting back on gender data gap, whether it's our human resources or the way we measure back on our progress. Apply a gender lens to that and share your story. You might be surprised how great it is. And then thinking about the institutional policy. Use some of those lessons, that inspiration, to change our environment locally. And then finally, a simple thing that all of us can do and might be doing is think about mentoring and sponsoring the next generation of women leaders, and that can go a long way. So it begins with a village to make a change. And as we're thinking about building our health systems, I really encourage all of you, greater gender equality equals greater development. Embrace it. Thank you.